Hey there, I'm Dr. Scott Worden, the TOS guy. It's my honor today to introduce Dr. Tracy Newkirk. Dr. Newkirk is a neurologist who's practiced in the San Francisco Bay Area for 45 years. And over the last 30 plus years, he's seen a ton of TOS patients. He is our go-to man for diagnosing these patients, whether it's ruling in or ruling out. Dr. Newkirk, besides all his extensive experience, has also invented and developed over many years a specialized vest called a body buoy that is an incredible piece of engineering and helps TOS patients. Maybe we can ask him about that later. So today I'd like to introduce neurologist Dr. Tracy Newkirk.
Hello, everyone. So now you know what a West Coast neurologist looks like, and I hope to teach you what he sounds like. We're going to talk again about thoracic outlet syndrome. What I'm really going to try to do is allow it to make sense. I will hold the position that thoracic outlet syndrome is so easy to diagnose, everybody can do it. It may be easier for lay people outside the medical profession, free of prejudice, to make that diagnosis than it is for specialists who seem to be able to look at the syndrome only through their specialized eyes. Surgeons kind of look with knives in their hands. Radiologists kind of look for images in their hands. Neurologists tap on reflexes and do nerve conductions, and then they miss it. So let's talk about the language of thoracic outlet syndrome and realize how that language actually teaches us how to figure out what's happening. So as you know from what Dr. Worden has told you earlier, and Steve Talakowski, the physical therapist, the thoracic outlet in current terminology, and years ago there was disagreement, but right now we're talking about this space at the root of the neck, on either side, above the collarbone, over the top of the lungs on both sides, and in front of the shoulder blades. It's a space that we'll loosely refer to as a compartment. More importantly, it's a neurovascular compartment. But if each of you understand what's in that compartment, and then what the functions of those components are, you'll discover quite happily today that making the diagnosis of thoracic outlet syndrome is actually rather easy. I'll even go so far as to suggest that probably more than 100 million people in the United States have this syndrome. It's just labeled differently and therefore treated differently. Okay, so let's start with this idea. What is a neurovascular bundle? This is an important concept since all types of animals, including humans, we think we're at the top anyway, all animals with skeletons, in other words, vertebrates, have neurovascular bundles. That means that nerves, arteries, veins, and lymphatics run roughly together, bound together by fibrous tissue. Now, there are variations in that, and we don't need to worry about it. If I start to get into those, I'll be talking to you for 5 hours and we'll all fall asleep. We don't want that. But the bundle that's deep to the collarbone in the thoracic outlet has the brachial plexus, those are the nerves, and the plexus, the trunks and all the branches have arteries, veins, and lymphatics. So I think it would be simply common sense to say that if we were to attempt to diagnose thoracic outlet syndrome, we should do a history and an examination that purports to examine the functions of all the structures, which then sort of puts a lie to the definition that you see in textbooks and on the internet, because those definitions say there's a neurogenic TOS, there's a arterial TOS, there's a venous TOS, and there's a disputed TOS. Well, I'll submit to all of you that the dispute lies in lack of attention to detail, and there's really no dispute at all. So we're going to talk about a series of symptoms and disabilities. So there we go. That's the definition of syndrome. A syndrome is a collection of symptoms and disabilities that can reasonably be attributed to a common cause. So that'll be our leading definition of syndrome. And when we say thoracic outlet syndrome, we're talking about compromise of neurovascular structures in this space called, for now, the thoracic outlet. Okay, so a neurologic examination that I tend to do all day long every day includes many things besides the thoracic outlet, but when in the peripheral nerve sense, we're looking for strength, movement, sensation, coordination. So if there is something compressing the brachial plexus, and we only ask about the nerves and temporarily ignore the rest, then you develop motor symptoms in the hands or arms. Now, here's the big surprise. The branches from the brachial plexus go front and back. So if you read things on the net or in textbooks, they talk about thoracic outlet causes numbness and tingling in the thumb and first two fingers, and some people in the fourth and fifth fingers and others. The sad part is that's the end of the discussion. So let me give you a perspective observation about the importance of that kind of omission. The nerves that originate from the neck, reorganize in the brachial plexus behind the collarbone, and then distribute to the chest and arms are literally huge pencil-thick trunks. So they're very major nerve pathways containing millions of nerves. But there are branches that go from the brachial plexus backward, or posteriorly, if you will, to supply the muscles that stabilize the shoulder blades. Those nerves, there are 3 or 4 sets of them, are literally no larger than the diameter of a human hair. They have very little insulation, they're very delicate, and in gross anatomy dissections, most people can't even see them. They're so small, it takes special techniques to localize them. Well, let's just think about the implication then of large nerves with heavy insulation compared to small nerves with light insulation. If some trauma occurs to the brachial plexus or a major nerve trunk with a combination of large, well-insulated nerves and tiny nerves, guess where the outcome is the most severe? Of course, it's in the tiny nerves with poor insulation. Now, let's set that observation aside and talk a little bit more about what generates activity through the brachial plexus. So, if I ask you the question, what have you done behind your back in your life that you got paid for? You think about that silly question. Well, the answer is absolutely nothing. Unless we're a stretcher bearer or some such thing, we do nothing of use behind our back. That means then the primary spinal cord activity triggered by brain or reflex will direct the vast amount of electrical activity anteriorly. In other words, to the chest and arm muscles. There's some variations on that theme, but that's the major principle. Then let's go to one more observation. I'll put these together in just a minute. Think of the professional pianist. The pianist, his or her fingers move like lightning. They're so fast, they're a blur. We now know by very exact measurements that nerve conduction along the nerves from brain to cord to arm and fingers is not fast enough for the brain to control all the movements necessary to play accurately a fast arpeggio on the piano. But it still happens. People can move their fingers with lightning speed and blurred action. So the reason that that can occur is subsumed under 2 categories. The art of music comes from the brain, but the mechanics of music come from the cord. So the ability to use our arms and fingers for useful activities is generated in the brain, but the mechanics are in the cord. The caveat that follows is, have you ever tried to outthink your own spinal cord? It's programmed to create everything we do in front of us. And unless specific measures are taken consciously, the large trunks of nerves from the plexus to the chest and arms predominate. Then think further about that. If most of the physical activity of chest and arms is anterior, and we're typing and driving and building things and cleaning things in front of us ourselves all day long, what wonder is there then that something happens in the front side of the body, not the back, to create problems? So rather than speaking of repetitive motion disorders or overuse syndromes, which are epiphenomena that are somewhat accurate, we should just think about the physical demands that confront our bodies and understand that there are structural changes that occur and that are unavoidable, frankly. And when one considers human anatomy, skeletal size tends to tell us what the consequences are going to be. So in a 6'4" football player who weighs 280 pounds all muscle, the space that contains the brachial plexus probably is 12 to 18 millimeters, not centimeters, not inches, but millimeters. And it turns out by experience that much space is pretty generous. So if a so structured, strong person, man or woman, spends a lot of time reaching, it really doesn't matter, because with 12 to 18 millimeters of space, nothing gets damaged. But then if we think of other people who are maybe 5'8" or 10 and slender and have to do a lot of reaching, that space may be as small as 4 millimeters or 6 millimeters. And we used to think that 6 millimeters would require surgery. We now know it doesn't. But if it's 6 millimeters at rest, prolonged reaching and realizing the fatigue of the periscapular muscles, which are relied on to keep the space open, occurs, then the tiny little nerves being opposed by these giant nerve trunks in front get overwhelmed. So the ultimate outcome of continuous reaching isn't so much repetitive strain or overuse, it's neurovascular fatigue, because there's not enough room for the blood vessels to supply the nerves. It's a very simple concept. And the interesting thing is, TOS syndrome is the only syndrome in which the symptoms teach us the anatomy. Think for a minute. If a person has a horrible migraine with a pain level 10 out of 10, a CAT scan of the brain or an MRI of the brain is invariably normal or shows minor changes that really have no clinical significance. That's not at all the case with thoracic outlet syndrome. When patients have headache, numbness, pain, weakness in their hands or forearms, constant pain in the neck and shoulders, we know from the symptoms what we're going to find in an MRI, such as Dr. Worden does, the MRI, MRA, MRV study. We're going to predictably see physical, bony, and muscular compression of the nerves and blood vessels that are incorporated into the bundle that's called the brachial plexus. Okay, when one does a physical exam then, and most doctors unfortunately don't do that, they look for what they're expecting to see, not what's actually there. So let's break it down. So what I'm going to do is just talk to you about what I see when I'm looking at a patient who may have thoracic outlet syndrome. And with that information, most likely any one of you can make the diagnosis of thoracic outlet syndrome. Whether anybody's listening to you or not, now that's quite another matter, because the listener only sees what he or she knows, not what can be discovered. So let's take the premise: thoracic outlet syndrome, by my definition, and I'll defend it as necessary, is always 99%, let's say, a bilateral, involves both sides of the body. So it's bilateral neurovascular compression syndrome. Now, here's the really interesting part, that eventually, not immediately, but eventually has local neck, shoulders, and chest, regional shoulders, arms, and hands, and shoulder blades, as well as remote consequences. So in other words, there are patients with chronic neurovascular compression in the thoracic outlet who not only have pain, weakness, numbness, contractions, all those things in both arms, asymmetrically so oftentimes, but they also have chronic neck and shoulder pain. And the important thing is bilaterally, not one side or the other, even if there's numbness in only one hand, there's usually pain on both sides of the neck and shoulders. So the chronic thoracic outlet patient, based on pure anatomic and physiologic grounds, also tends to have headache, sometimes fullness or numbness and tingling in the face, symptoms in both arms, pain between the shoulder blades, low back pain, sometimes inguinal pain, and oftentimes numbness and tingling in the feet, a balance problem, and in a few cases, even problems with bladder control. We know the pathways that can get involved with venous back pressure. So these are not strokes, these are not hemorrhages, anything terrible like that. Most of the remote neurologic symptoms can reasonably be attributed to venous back pressure with poor circulation at brainstem levels and at other areas, even in the spinal cord. Okay, let's go back to anatomy then. So assuming that most patients will to some extent be asymmetrical in their symptoms and disabilities, but nearly all of them, I'm going to generalize a lot today just to make the principles, but nearly all of them will at least have physical findings on either side of the midline, whether they have obvious symptoms on both sides or not. Okay. In the case, let's take everybody knows, they've heard about the brachial plexus. So the neurologic hardwired findings in rare cases could be so severe that there's atrophy of hand muscles or forearm muscles, and even one or more absent reflexes. In the textbook so-called neurogenic form of thoracic outlet syndrome, in which a cervical rib, an extra rib, is present, and mind you, I've seen probably 6,000 cases of thoracic outlet syndrome by now. I think I've probably seen neurogenic thoracic outlet syndrome perhaps 3 times or 4 times in the last 30 or 40 years. So it is really that rare. It's very obvious. When it's present, any neurologist can make the diagnosis, but if it isn't that rare form, and most neurologists have difficulty with the diagnosis because they're looking for objective neurologic deficits, they tend to ignore the shoulder blades, which is a cardinal error. And when they don't see drop reflexes or atrophy, then they lose interest. Well, that's really unfortunate, since 98 or 99% of the patients who suffer all of the time with all the symptoms we've mentioned and more won't be treated unless the significance of their symptoms is fully recognized. So the correct examination for thoracic outlet syndrome, therefore, is not a neurologic exam. It's not a vascular exam. It's a combination. And furthermore, the very specialists that claim to do the exams should be required to look at the lymphatic system along with the nerves, arteries, and veins. And unless they present information indicating that all these structures have been evaluated simultaneously, the outcome is usually at least insufficient and often incorrect. As you all well know by now, there are problems in the neck that can mimic thoracic outlet. There's the brachial plexus that we're discussing. And one of the more common errors is to mistake some of the symptoms for carpal tunnel syndrome or cubital tunnel syndrome, which is ulnar nerve compression at the elbow. Now, perhaps this is a good time to introduce another concept before we go back to the anatomic details, and that's the concept of double crush. As you well know, in basic math, 1 + 1 = 2. But in the peripheral nervous system, one compression plus another compression often creates a deficit greater than either or the other added together. So this is the only time in the universe that 1 + 1 may equal 3 or 4. Obviously, that's an artful use of the terms, but if there's a double crush syndrome going on at 2 different points in a nerve territory, the deficit often is much more severe. This has to do with decrements in nerve amplitude and frequency conduction. It's beyond the scope of this talk, but it is important to recognize it because there are a number of ways in which these double crush situations, as a matter of fact, one can even have a triple crush, one could theoretically have a herniated cervical disc in the neck, brachial plexus compression, and either carpal or cubital tunnel, produce a tremendous deficit that's never fully addressed by just releasing the carpal tunnel or taking out a rib or removing a disc. The problem in clinical medicine is that when a specialist attacks the nervous system in one place or another, once they've done that, irrespective of outcome, then they're done. The patient should be educated to continue the pursuit, because I've just pointed out symptoms in the little finger. I can think of 5 different places in the nervous system that might produce numbness or weakness in the 5th finger. So therefore, if one diagnosis doesn't make the grade, there's another one behind it. You have to just keep looking. Okay, so let's go back then to the basics of thoracic outlet as a syndrome, thoracic outlet component compression. So I've pointed out already, there are major nerves from the plexus that go to the chest and arms, but for vascular integrity, the tiny nerves that go posteriorly or backward to the shoulder blade muscles are often the most important component. Think of the scapulae as the stakes and the cables in a tent situation that you tighten them up, it raises the roof of the tent. So the more strength there is in the periscapular muscles, the more likely it is that the collarbone in front will be stabilized. And when it's pulled backward from the scapula, the clavicle actually rotates up and out it's not a straight line. It makes more room because of the curve. We have to therefore maintain the integrity of the periscapular muscles to preserve the space that contains the brachial plexus and its blood vessels. All right, so when the brachial plexus itself is simply irritated and not permanently damaged, then neurologic electrical studies will be normal, and neurologic reflexes will be normal. But the motor or nerve-based functions that will not be normal are that there will be grip strength weakness, and most importantly, the shoulder blades will not be in correct position. So I'm not sure how well this can be illustrated, but I don't want to go into diagrams. I want you to realize that the simple physical anatomy is all we need to know about to make the diagnosis. So pretend that my hands are the shoulder blades. So this is the way the shoulder blades would look from behind. The spine is in the middle, and the shoulder blades should be outlined fairly symmetrically and equidistant from the thoracic spine. In most cases, in thoracic outlet syndrome, if one looks carefully at the shoulder blades and even nothing else, the first thing that's noticeable is there's ptosis. So this is spelled T-T-O-S-I-S, ptosis. Ptosis means drooping. Eyelids, breasts, all organs can droop. The shoulder blades can droop. If the shoulder blades are not supported and they tend to slip downward, it won't be a huge move, but they often do it asymmetrically. And the positioning of the shoulder blade determines the rotation of the collarbones in front, and therefore determines how much room there is for the brachial plexus. All right. So assuming this is the normal shoulder blade position, it's commonly shifted something like this in thoracic outlet syndrome. But the next most important thing that happens is the shoulder blades slip laterally. It's this displacement that again puts torque here on what's called the AC joint, that it tends to force the clavicles in. And on Dr. Worden's MRIs, this is all measurable. We can prove that these abnormal anatomic changes are occurring. So back to the shoulder blades, there we'll line them up that way. So we're getting ptosis, lateral displacement. There's often a malrotation because the rhomboid muscles that attach to the spine start to fail in this direction, so the shoulder blades slip out. Then there's another concept that's very important to learn about. You hear the term scapular winging. Now, there's a very classic syndrome that all neurologists and most everybody else knows about, paralysis of the long thoracic nerve. So some major force that strikes down in this direction is often called a carpet layers palsy from carrying rolls of carpeting, or falls can do it. If the long thoracic nerve is paralyzed, and one of the shoulder blades just looks like a shark fin. It pops out away from the chest wall. It's very, very prominent. And the medial border often is 2 to 3 centimeters off the back of the chest wall. That's not what happens in most cases of thoracic outlet syndrome. Instead of something sharp change like that, the situation is that the medial borders slip away like this, away from the chest wall. That can be up to 1 or 2 centimeters. But the point is, this rotation, as well as the slippage in these directions, all cause abnormal forces on the collarbones, which rotate off the top of the sternum and compress the neurovascular structures. Now, is this true, and how important it is? It's very easily illustrated. Let's go back to the definition. Thoracic outlet syndrome is a neurovascular compression syndrome. It's not a stroke. It's not a heart attack. It's dysfunction due to impairment, potentially reversible impairment, of nerve and vascular studies. Aha. So there's a very simple next step. If malpositioning, I'll try to get in the center here, malpositioning of the shoulder blades is causing the compression up front, if we fix the positions of the shoulder blades, we ought to relieve the compression up front. In fact, that's the exam I do every single day in the office. If I think the patient has thoracic outlet syndrome, this is what I do. I ask them to review all their symptoms tip to toe. Remember, I said the definition of thoracic outlet includes local, regional, but also systemic symptoms. So, for example, if the patient has a headache, blurred vision, numbness and tingling in most of the fingers of either hand, low back pain, and tingling in the toes, and if they haven't come to end stage progression, relieving the compression of the brachial plexus and its consequences should relieve the symptoms, and furthermore, relieve them immediately on the spot as we watch. So, assuming the patient is sitting in front of me and here are the shoulder blades, they're in this kind of a position, I simply take my hands and move the shoulder blades from this position into that position and hold them there. Then sometimes we use tape to hold it in position, and we can measure blood flow and vein diameter and a lot of other things. But most of the time, and mind you, not all of the time, because there's a lot of individual variation in the syndrome, most of the time, within 30 seconds of restoring, I'll get my hands right here in a minute here, restoring scapular position, headache goes away, hands warm up, numbness and tingling goes away, and most of the time the patients are utterly astonished to realize their low back pain has gone away and the tingling in their toes has gone away. Now, most patients with this syndrome with disseminated symptoms also have trouble with their balance. And this is not a stroke. They simply can't tandem walk with one foot in front of the other. So we tape the shoulder blades with strong tape back into neutral position immediately, not sometime later, not the next week or month, but within the minute, these patients can walk heel to toe in a very normal fashion. So indirectly, once you've done this kind of exam 10,000 times, you start to believe that it's real. So by relieving compression of the neurovascular bundle, the anatomic relief produces immediate improvement, depending on the extent, of course, of hand symptoms, elbow pain. This is one of the more common things that people don't realize is due to thoracic outlet syndrome. But what the folks of you who are listening right now should realize, it also takes away the headache, numbness, and tingling in the feet. I don't want to leave this in a too deeply mysterious state, but I'll try to point out an anatomic fact that helps you understand how moving the shoulder blades can clear a headache, as well as improve neck pain and improve neck range of motion. So as you well know, blood goes from the heart via arteries to the whole body. When it comes to the brain, the carotid arteries in front and the vertebral arteries in back carry all the blood to the brain. But the venous return back to the heart is a more curious pattern. The blood inside the head tends to gather and come around in a pattern, so most of the blood returns through the jugular veins. Now here's the very important observation. The internal jugular veins are very large veins, but right behind the clavicles, they have valves. They're called bicuspid valves. So if there's a pressure problem in the thoracic outlet, it hits the valves. It does not move up the internal jugular veins. But the external jugular veins, which are farther out to the sides, have no valves. So if there's increased venous pressure in the thoracic outlet, which there always is, there are various ways I could teach you to measure that. You could all do this on your own. It doesn't require a doctor to figure this out. Back pressure through the external jugular veins causes distension of veins inside the head, not the brain, but inside the cranium. There's a system of nerves supplying mostly the face, the fifth cranial nerve. It's called the Trigeminal Vascular System. That system immediately senses venous distension along with arterial changes, and that's one of many triggers that sets off a process called neurogenic vascular inflammation. That is the pathophysiologic mechanism of migraine. It's amazing that if one reduces that venous pressure, a headache of 5 or 6 over 10 can go to 0 or 1 in the space of a minute. It's an utterly amazing, totally reproducible phenomenon. As a matter of fact, mechanical correction in these situations is much more effective than pharmacologic correction. Point being, if one maintains normal venous return from the brain by correcting the thoracic outlet compression, there's a mechanical solution for headache, which makes that syndrome much easier to treat. Now, the one part of thoracic outlet syndrome that is uniformly overlooked, not all the time, but most of the time, is the lymphatic system. So this is something you can all observe on your own. So the top of the sternum is called the manubrium. The collarbone goes out to the shoulder joint, the AC joint. So the space above the collarbone, literally the width of one finger above the collarbone, is called the supraclavicular fossa, or space, if you will. In the normal state, that space is concave. In most cases, not all, because slender women and slender men don't have much edema. And the truth is, we don't even know why. We predicted years ago the slender people would have the worst edema, and it turns out they have the least. That's, again, slender people develop edema if their syndrome gets much worse, but in the early stages, there's none. But I have a grading system that's often very helpful to understand how important the lymphatic system is. So, in principle, the space immediately above the collarbone should have a depth equal to the width of the individual person's index finger. Then, by inspection and palpation, and I have a system that goes from 0 to 4. So 0 to 1 is normal because there's really no detectable swelling. After you do this 10,000 times, you can pick up minor swelling, but there's no reason to think that's clinically important. Then we use the number 2 plus to say that the space is half filled in. 3 plus means it's flushed with the skin, and 4 plus means it's swollen. 4 plus edema is a fairly serious situation. It doesn't lead to blood clotting, but it says that the underlying inflammation is very intense. It usually only occurs in chins that are advanced. Well, suddenly we've come up with a practical definition with visual observations that anyone can tell. So a neurovascular bundle then should have neurologic, lymphatic, venous, and arterial findings. Okay, so what about the venous system? I've talked about the physiology in the brain, back pressure up to the external jugulars can produce headache. But there's another physical finding that's much easier for you to observe. So I've discovered it won't show up well on the screen, but in theory, if you sit hands in lap, you'll notice in most people, unless there's hand swelling, that the veins are dilated. They puff up the skin a little bit. You can see the venous tracts in the back of your hand. It is normal if one produces a 90-degree shoulder flexion angle, so straight forward, the veins that you visualize in the back of the hand should be empty. If thoracic outlet syndrome is present, greater on one side or the other, it requires more hydrostatic pressure to get the veins to empty. So if the veins empty at 90 degrees, hand veins, it's normal. Up to 130 or so, there's mild compression. Up to 155, it's moderate compression. Above that, it's severe, may even be pre-occlusive. So I always look to see what the shoulder angle is for venous emptying, because that gives me an immediate anatomic variation of the severity of compression of the venous system behind the collarbones. The most difficult part, even though it gets the most attention in the literature, is to evaluate the arteries. So those of you who have read about the syndrome may know about Adson's maneuver and things of this sort. Remember, all the clinical signs are just that. They're clinical signs, so one of them proves the diagnosis. If one, though, has abnormal elevation for venous emptying, irritation of the hands with numbness and tingling on stretching, edema above the collarbones, and a pulse that disappears in certain positions, there's nothing else, no other syndrome can do that but thoracic outlet syndrome. When doctors do only part of the exam, then they're misled into thinking there's some other problem going on. Now, the arteries, as I said, won't always occlude or change in one arm position or another. So therefore, when doctors say there's no TOS because Adson's was negative, it's fully irrelevant. There are normal people with no other symptoms. Some have positive Adson's, some have negative. So again, no one sign is useful. It's the symptom complex and the collection of physical findings that determine the probability of the diagnosis, the importance of the diagnosis on either side. So when patients point out that they have symptoms mostly in one hand, the doctor should look for evidence, whether symptomatic or not, of involvement of both upper extremities on physical exam and the presence of symptoms that are remote, such as a gait disturbance, headache, or tingling in the feet. So what we've just done in fairly short order is to define a neurovascular bundle. That's a collection of nerves and their arteries, veins, and lymphatics that perform based on their location, tight space in this particular case. The consequences of prolonged compression have to show up as neurologic, venous, arterial, or lymphatic findings. Because of the major size of these structures, obstruction will eventually produce symptoms remote from the anatomic space. So again, back to the definition, thoracic outlet syndrome is a neurovascular compression syndrome with local, regional, and head to foot symptoms with disseminated findings. Fortunately, Dr. Worden has carried forward the imaging study so that we now can put millimeter measurements on nameable, visible structures that correlate exactly with the symptoms that we're talking about. Then whether the management is conservative or surgical depends on the duration and degree of the disabilities. So surgery is not needed very often. In our population, we think surgery is needed probably 2 or 3% of the time and no more than that. And oftentimes it's needed if there are structural abnormalities that can't be avoided, such as extra muscles or an anomalous configuration of the clavicle or some such thing as that. Most of the time, if there's enough scapular support, there's enough opening to recover. So this is a short form view of a very simple but highly reliable, anatomically based set of circumstances that can be seen by anybody, verified by anybody, and help support the diagnosis. Whether one does imaging or not depends on the intensity and duration of the symptoms, severity, distribution, and the potential need for surgery. In our opinion, in this general area, no one should do surgery until they know what the anatomy is. A venogram, an arteriogram, or some such thing is never sufficient. It does not reveal all the variations in anatomy. Even a brachial plexus neurogram, which gives us a pretty good idea of the shape of the plexus, is usually done only in one position. Now, let me make one other point before we open it up to questions in case there are any. Most of the imaging that's done correctly is done with the patient lying on the back. That means body weight is on the shoulder blades. I just pointed out earlier in this presentation that manual correction of the shoulder blades relieves the symptoms. So while the MRI, MRA, MRV study is the most valuable anatomic objective test we can do, it minimizes the degree of compression because the body is on the back. Now, there is such a thing as an open upright MRI, but it has much too narrow a point of view, and the imaging is kind of blurry compared to the closed one. So our habit, at least, is not to use that form, but to rely on the type that Dr. Worden does because it gives us the most accurate view. Okay, what I think I'll do, because I've gone on for quite a bit now, is I'll wrap up my part, and then I'll look for any sign of question from anyone out there that wants to know more about this. Actually, I see one here that I should comment on. The question is, what's the difference between cervical disc disease and thoracic outlet syndrome? The easiest is to point out that thoracic outlet syndrome, irrespective of the symptoms, nearly always, like 98% of the time, nearly always has bilateral findings. In cervical disc disease, there may be neck pain, which is localizing or non-localizing, and some restriction of motion, but by definition, there's no cervical disc that can involve both sides at the same time. So a cervical disc protrusion will produce pain, weakness, numbness, or a combination in one extremity, depending, and the level depends on whether it's the thumb involved or the little finger or something in between. With thoracic outlet syndrome, I know this is a repeat, this is the third or fourth time around, it's very important that the examination look for bilateral findings, even though the complaints or the symptoms of disability seems to the patient to be mostly one-sided. If we then remember that thoracic outlet syndrome has local, regional, and systemic or remote symptoms, putting all that together provides an unmistakable proof of the thoracic outlet syndrome. Okay, another one has come up. Can nerve compression syndromes, cubital tunnel included, cause changes in hand color or temperature? Oh, no. Or is this possible only from vascular compression? Well, vascular compression certainly can do that, but the caliber of blood vessels is controlled in part by the sympathetic nervous system. So there's absolutely no question that color and temperature changes can occur in thoracic outlet syndrome as well as in peripheral nerve compression syndromes. Again, it goes very much to the issue, therefore the exam ultimately must control. Because you can have a cubital tunnel syndrome with or without vascular signs, or carpal tunnel, either one, but there will be other findings in the neck or even remotely that tell us it's much broader syndrome. Again, remember, this raises yet another question, and that is double crush or triple crush. So can you have cubital tunnel syndrome and thoracic outlet syndrome at the same time? Now, that's unusual, but absolutely yes. There's no reason to think that can't happen. But that's sorted out with two combined methods. So if I were going to have to answer the question, then I definitely want to do the MRI exam that Dr. Worden does, because then I'll know to the millimeter how much potential compression of the thoracic outlet there is. And then what I would also do, in addition to possibly nerve conduction studies that localize compressions, is to do a manual reversal of the scapular weakness to find out then how much of this clears up. So if you combine imaging studies with electrical techniques and the specialized thoracic outlet exam, it's almost always possible to get the right diagnosis. It's one or the other or a combination, and in what percentage. So careful attention to detail. Remember, the devil's in the detail, but so is the diagnosis. So if you look at local, regional, and systemic consequences, and then a careful neurovascular exam, not just a neurologic exam, the answer is almost always obvious. Okay, are there, oh, here. Oh, can thoracic outlet be a cause of migraine? I see migraine due to thoracic outlet syndrome essentially every day I'm in the clinic. As I tried to point out earlier, there are no valves in the external jugular veins. There's one on each side, but there are big valves in the internal jugulars. But we now know with good evidence that back pressure through the external jugular veins dilates the venous system inside the head and produces pain. That pain is identical to the migraine that occurs spontaneously in other people. But here's what's really important. That headache can go to zero in less than a minute, often 20 seconds, with bilateral, manual, hands-on scapular correction. I had 2 patients today with headache, 3 to 5 out of 10, and with a simple scapular maneuver, the headache went to zero. I've had the opportunity to do this simple maneuver thousands of times. Now, there's another caveat that has to be kept in mind. That's the concept of the migraine-prone brain. So patients with migraine have a very good brain, but the migraine brain tends not to filter certain stimuli very well. So the migraine patient is often sensitive to light, sound, smell, even movement. They get vertigo and that sort of a thing. But that brain is also unusually sensitive to venous back pressure. So whereas I've just said to you, in this office, we routinely can clear up a headache with a scapular maneuver based on anatomy. If patients have fairly difficult migraine, that won't clear up all of the headaches. Fortunately now, actually since the fall of 2018, we have 3 self-injectable monoclonal agents that prevent nearly all the migraine, except those triggered by venous back pressure and thoracic outlet. There are half a dozen other agents taken orally with almost no side effects. It's astonishing how good they are. It also takes away the headache. So by treating thoracic outlet along with a migraine program, you can often produce a phenomenally good, sustainable, safe relief of the headache syndrome entirely. Okay, another question has popped up. What purpose is a vascular, arterial, and venous Doppler in the supine position, arms at rest? Well, the first answer is maybe nothing, or that's answered strictly in terms of having thoracic outlet syndrome. Certainly, patients with vascular diseases, atherosclerosis-related problems, or aneurysms, then the Dopplers in the supine position can be extremely helpful. But as far as being helpful in making the diagnosis of thoracic outlet syndrome, I don't really find them useful at all. Can thoracic outlet syndrome develop after breast implant surgery or a breast implant removal? Well, it can, but the real issue is, are they related or not? Okay, there are no direct ways that surgery outside the muscular chest wall should produce thoracic outlet syndrome. But if we think a minute, in slender women, for example, who have a narrow space normally, and then have disability-related pain or contraction of surgical scars, there's a tendency for the shoulder on the symptomatic side to move forward. It's a myofascial response to inflammation, worse if there's been an infection. So if there's a slender individual and there's traction on the pec major or minor muscles that pulls the shoulder forward a little, quite indirectly, that could trigger thoracic outlet syndrome. I've seen that just a few times over the last 20 or 30 years. And the only way to treat that is not more surgery, but there are painful, slow, but useful myofascial release techniques to try to loosen the chest wall, and then very rigorous exercises or orthotic correction or both to pull the shoulder blade back into position that will also help relieve thoracic outlet syndrome. So this is more a skeletal collapse from the outside than a compression that evolves within the space that contains the brachial plexus. Should one be concerned with lymphatic swelling? Okay, that's actually a question that almost never gets asked, so I'm really pleased to hear about it. So, lymphedema, or lymphatic accumulation above the clavicle, either, and it's usually bilateral, so therefore it's not a tumor or something of that sort, indicates inflammation of the brachial plexus, obstruction of the local lymphatics, or both. Now, when significant lymphatic edema or swelling there is present, it tells us that the thoracic outlet syndrome is really quite severe. It's not mild or moderate, it's moving in the severe range. But there's a really interesting phenomenon which proves, and I have to confess, none of us understands the lymphatic anatomy very well in this space. We all know about the big thoracic duct and we have a general idea what the drainage patterns are, but we have no idea nor any way to image individual variations. So whereas I view the lymphedema as a sign of moderate to severe thoracic outlet syndrome, it does not necessarily mean moderate to severe disability. The curious phenomenon is, with correct physical therapy for thoracic outlet syndrome, in which the patient says, I don't have headaches anymore, my hands don't go numb, my grip strength is getting better, the edema may not go away. So in that particular situation, edema loses its ability to predict the severity of the syndrome. What's even curious is what happens to the lymphedema after rib resection, after surgery for thoracic outlet syndrome. Most of the time, entirely. Now that's a very interesting thought because in that surgery, the anterior and middle scalenes are removed. We do know from direct observation that there's a massive collection of lymphatics, mostly on the middle scalene, but somewhat on the anterior scalene as well. So one would think, well, wait a minute, if we inadvertently take out many lymphatic pathways, the lymph fluid should build up. So in that sense, we should expect greater lymphedema after surgery rather than less. Well, 90% of the time, there's a lot less. So apparently, opening up the venous space, as well as some of the lymphatics, is a good thing. But 5 to 10% of the time, we have very successful rib resection. Pain goes away, grip gets better, headache goes away, and the edema never goes away. So that means in some cases, there are lymphatic patterns that, even if they're deleted, don't seem to make any difference, but in others, inadvertently, removing those lymphatics causes persistent edema. Fortunately, if the major compression of the nerves, arteries, and veins is accomplished, the syndrome gets better anyway. So the ultimate confession is, we don't very well understand the lymphatics, but fortunately, if we focus on everything else, we still do all right. Okay, another question. Oh, okay. So this is a question about the vest that we're talking about. I hadn't intended this to be an advertising event, but so let me just present it this way. Symptoms and disabilities inevitably result from varying degrees of mechanical compression of the brachial plexus and its arteries and veins and lymphatics. Common sense would dictate, experience proves, that relief of that compression will reduce or reverse all the symptoms and disabilities related to dysfunction of nerves, arteries, veins, and lymphatics. In the broadest sense of the term, there are 3 approaches to correction of thoracic outlet syndrome, all designed to improve, make more room at the end, in other words, make more room for the guests and structures. So physical therapy is tried and true, but remember, this is not physical therapy to the neck primarily. It's mobilization of the pectoral muscles and strengthening of the periscapular muscles. End of discussion. If we don't accomplish that, ET will fail. I have a paradigm that I teach my patients. If thoracic outlet syndrome has been present for 6 months, it takes 6 months to reverse it. If it's been there a year, it takes a year. If it's been there 2 years or more, we can't claim to reverse it completely. Most of the time, we can do a pretty good job, but not always. Okay. Therefore, if one doesn't want to spend 2 years with correct physical therapy, the next easiest way to open the space is what we call the vest or the body buoy, like a life buoy, orthosis. This is a garment. It looks like a vest. It zips up in front. I'm a slow learner. It takes me 20 to 30 years to figure out how to make this work, because it turns out pulling the scapula together without rotating the clavicles inward through compression devices is very difficult. I naively thought years ago I could do months. 30 years later, we're still working on variations. This like garment, it can wear under or over clothing. It zips in front. It has straps that have been very carefully, painfully designed to move. When you tighten the straps, the shoulder blades move in and up. We can augment that with an extra pad called a cara pad. What does that mean? The biologic name of a turtle shell is carapace. So the cara pad goes in back like a shell. It's designed to compress the shoulder blades just enough, medial borders, so that when the straps are tightened, shoulder blades are pushed flat to the thorax and moved up and in. So it's kind of a reverse swoop. So this can be worn all day long. It creates an immediate compression. Moderate headache, put the vest on, the headache goes to 0 in less than a minute. So we have pretty good evidence that this is the correct anatomic device to use in principle. Unfortunately, because of insurance concerns, we have very few of the point. But to date, over the last 20 years, we have a total of 3 MRIs done with and without the vest. Each one of the 3 images with the vest showed that the costoclavicular interval, the space by the plexus, increased about 6 millimeters. It opens up. So the back buoy support we put in chairs just supports the lower blades. That opens the space by controlling the scapular wall. That controls the scapula ambulatory. Nothing's perfect, but this particular device works for all those parameters well over 90% of the time. It may be higher, but it sounds mostly like braggadocio. It is a device that moves the scapulae where they belong and holds them there. If one then does correct physical therapy exercises with that space open, the rate of recovery is much faster. We don't ever intend that someone wear the vest the rest of their life. That's not the goal at all. But it's like trying to exercise your grip with the tourniquet on your arm. If there's no blood flow, your strength doesn't improve. Well, if the blood flow to the plexus there's not much gain. So this is a simple way of moving the tourniquet. This time for leather, it's made of skin, muscle, and ribs and clavicle. It opens up that space. It gives physical room for the blood flow to the plexus so it can strengthen the muscles and ultimately correct the syndrome. That's a simple presentation. It looks like a vest with straps. That's how to summarize it. Oh, the next question is thoracic outlet causing pain and tingling in the legs. So there's no definition in any paper or textbook that includes lower extremity symptoms. But if one understands, once you've examined 5,000 or 6,000 people, you kind of catch on. It takes a while, but we catch on. So if there is, and we know there is, back pressure due to thoracic outlet in external jugular veins, we have reversible. That back pressure into the brainstem causes spinal cord related symptoms. So the common symptom complex from brainstem due to thoracic outlet is a combination of difficulty controlling the bladder. It's called pelvic floor dyssynergia. low back pain that does not radiate into the buttocks or legs, a gait disturbance in which the narrow base is impossible. People have to walk a wide base gait, but they also have unilateral or bilateral numbness and tingling in their toes. The way I distinguish, first of all, the numbness and tingling is intermittent. So therefore, this is not neuropathy. This is not a nerve disease. If you get neuropathy for any of the 250 causes, once it's there, it stays there and slowly progresses. It doesn't come and go. The numbness and tingling of the toes and thoracic outlet comes and goes. So this is a test you can do for yourself. If an individual person has thoracic outlet related cause, numbness and tingling in the toes, if someone takes hold of the shoulder blades and moves them in and up and does it correctly and holds it for 20, 30 seconds, more than 95% of the time, the numbness and tingling will disappear and will stay away for the duration of the correction, coming back within a minute once the scapulae are released. So the common sense of it is do something about those shoulder blades so they stay in the right position, thereby improving gait, bladder control, and getting rid of the numbness and tingling. There are other sensory symptoms that occur on the legs, but by far the most common is intermittent. Hear me again, please. Intermittent, not persistent, numbness and tingling of the toes of either or both feet. Oh, we have another one. Oh, okay. Now Scott's going to put a lie to everything I said.
The knowledge. It's so cool.
Okay, now I can hear you. Okay, I couldn't hear you first, but now you're coming through.
I said I never cease to be amazed by your depth of knowledge. It's amazing. I know I can always come to you with questions as we try to learn more. There was a really cool question about lymphatic congestion, and I just wanted to help clarify for TOS awareness. As Dr. Newkirk described, the veins are low pressure, the arteries are high pressure, the veins are low pressure, and the lymphatics are even lower pressure. The thoracic trunk that he mentioned actually empties into the left thoracic outlet, so it can be compressed by the same mechanism that the veins are compressed. And therefore, as Dr. Newkirk talked about venous congestion causing all kinds of symptoms like in the head and neck and in the lower extremities, well, if we've got venous congestion, we can also get lymphatic congestion, and that can cause just this diffuse, poorly defined swelling like here in the supraclavicular fossa. It's a really good question, and we believe that that venous congestion and lymphatic congestion will take spaces that are already narrow and make them more narrow, right, Tracy? You can expand on that.
Yes, that's absolutely true, but this is another important corollary. Keep in mind, water flows downhill. Lymphedema is a water-like fluid. It's not water, but it's water-like. If it builds up in the space above the collarbones, eventually it moves. So with careful palpation, very like safe cracker finger touch, that edema actually can be detected throughout the chest wall. In women, sometimes it can produce breast swelling. It also causes swelling of the hands. And that's one of the reasons sometimes venous signs can't be seen, because the hands have more fluid in them than they should. So if scapular correction is done by any means, most of the time the swelling above the collarbones will go down, but also you get better finger motion, the skin is less tight, people feel congested, they have trouble breathing, because the soft tissue spaces of the thoracic area, front and back, are often filled with fluid. I've reviewed hundreds upon hundreds upon hundreds of examinations by other physicians, and never once have I seen reference to edema above the scapulae. Nobody ever looks. I see edema around the scapulae 2 or 3 times every single week, simply because I actually look. If you consider how edema can occur there, it leads us directly to the thoracic outlet. So the lymphatic findings, if one only thinks about anatomy and physiology, can tell us alone that a patient has thoracic outlet syndrome, because nothing else could possibly do that. Another question has just popped up here. Botox is a diagnostic test for neurogenic thoracic outlet. can it be helpful in the other? So depending, it's usually a scaling block with Botox. But if you think about the way I defined this, if you paralyze the scalenes, oftentimes, not always, and we don't know why not always, the thoracic outlet symptoms improve. But it isn't that it's a neurogenic improvement only. If one actually does a 4-system exam before and after Botox on one side, one may see less edema. One may see the veins empty more easily. One may see the disappearance of neurotension signs. I didn't illustrate the whole pattern, but so it's not that one or the other thing gets better. Everything gets better if you only know how to look for it. So my educational clue is this is a syndrome that includes 4 systems, not nerves or veins or arteries, and it must include all 4 because these are in a bundle. So again, my colleagues who talk about neurogenic this or that, it's simply a predominant presentation, but if you look far enough, everything else is there as well.
I might add, that's a good question by the same person I just mentioned before, TOS awareness. I would point out that there is some evidence, we don't know the mechanism, that Botox or lidocaine injections into the scalenes can improve the grip strength and the work capability of that upper extremity. A surgeon who's now retired, unfortunately, Dick Braun in San Diego, published a paper on it. But for years, he would do pulse ox measurement of the oxygen at your fingertip that we see now with the virus that's going around. And he would also have people use a BT machine, a physical therapy machine that could be measured. And he would have them do exercise before and after these scalene injections, and they improved in TOS patients. So that's a good question. There's a lot we still don't know about that. Tracy, I do have a question for you because we get lots of patients who ask us at Vanguard, when they see a doc and the doc gets them an EMG test that's negative, where the doc tells them it's just whiplash, when should those patients start thinking about TOS?
Immediately. Because first of all, whiplash producing unilateral symptoms is essentially impossible. Whiplash is a term we should never use because it implies changes that we really can't prove. And the bottom line is this: if there's a pain syndrome involving the neck and both shoulders, and if there's anything else, numbness and tingling in one or the other foot, numbness and tingling in one or the other hand, it can't just be whiplash. So because that's an orthopedic muscular strain syndrome. So by definition, there can't be numbness, weakness, cold blue hands, or veins that don't empty, that sort of a thing. So if there's anything besides neck and shoulder pain on both sides, anything in the feet or hands, the next most likely explanation is thoracic outlet syndrome until proved otherwise. The general medical thought process is, oh, it must be a disc, it must be a this, it must be a that. And the lie to all that reasoning is there's only one kind of syndrome that produces asymmetrical bilateral symptoms, and it sure can't be a disc. I mean, there are things like spinal cord tumors I can talk to you about, but they don't come on after trauma, and they don't come on with reaching. I mean, it's really if we just think about simple concepts, this is a really easy syndrome to diagnose. Doctors make it hard by thinking specialty first and outcome second. Think about what you actually see, touch, feel, and sense. And that leads us to the diagnosis nearly every time.
So most of those patients will have had a cervical spine MRI. So what you're saying is if they have symptoms in both arms, regardless of a negative EMG, regardless of their doctor telling them whiplash, they should be thinking and reading and learning about TOS.
Absolutely. And if nothing else, they might have both. But if you don't deal with both, the syndrome's not going to be cleared up.
So I would just add that somebody here has requested a physical demonstration of the correction you do with the scapula. I don't know how hard that would be to do now. We can certainly promise that we'll get you with a volunteer patient and demonstrate that in a very near-term video, unless you think you can demonstrate it.
I'm here alone, so I can't do it that way. But okay. Number one, we'd certainly be happy to demonstrate in the future. Number two, the concept is so simple, it doesn't need much of a demonstration. So basically, vest correction, body boy support, back boy support correction, or manual correction, or tape correction, all do the same thing. If these are the shoulder blades, we simply move them towards the midline and move them up. Now, mind you, here's an interesting observation. I've learned enough about scapular movement. I can have a patient sit in front of me with a headache on the left side of the head, and I can move the shoulder blades and move the headache to the right side of the head. Or I can move them both far enough and get rid of the headache entirely. Or I can put a traction mechanism in and create the headache. These people thought they had to take Advil or Aleve or codeine for their headache when it's a neurovascular event. That, I used to say I play piano and now I play scapula. But the result is we can prove the origin of head symptoms, neck symptoms, arm symptoms simply by changing the location, the physical configuration of the scapula on the posterior thorax, the upper back is the other way to say it. So up and in, reverse the Nike swoosh, whatever you want, up and in, applied to the chest wall, and that's the correction. The trick is, because of the tiny nerves, the microscopic almost nerves that supply these, is to get that correction in place and hold it despite the traction from the huge muscles of the arms and chest. That's the challenge. The principle is really, really easy. The mechanics are really, really hard.
Every time, Tracy, every time the man with 35 years of experience says, this is really easy, I have to say, it's not so easy. I've been doing this a long time, but it's challenging. So I think we should set that up soon. A physical demonstration will get a volunteer. And I really appreciate that question. And I think it would be a fascinating thing to watch for me too.
Good. But if the resolution in the imaging here is good enough, with that correction, not only does the patient say the headache's gone, but you can see the veins empty, the neural tension disappears. I mean, the outcome is immediate, very gratifying, but making it hold, now that's where the art comes in. That's the challenge, and that's what we've been practicing for the last 30 or 40 years. I think we wrapped it up.
All right. I think you got through all those questions. I really appreciate you sharing some of your expertise with us, and I hope you'll come back with us soon.
I'm happy to do it. It's fun for me.
Thank you. And for all the viewers, I really appreciate not only a lot of questions, but really good questions. I think, Tracy, these are people who have read a lot about TOS, and it's great to see empowered patients, isn't it?
Yes, it really is. But remember, anatomy always wins. So if somebody's confused, if we get the anatomy right, we're probably going to get the diagnosis and the correction right eventually.
Awesome. All right. Thank you, everybody. Really appreciate it.
Thank you, everybody, for listening.
Thanks, Tracy.